Our next speaker is Dr. Raghu H. Ramakrishnaiah. He has obtained fellowship in neuroradiology in 2009 and pediatric radiology in 2008 from University of Arkansas for Medical Sciences, Little Rock, USA. Sir has obtained American Board certification in neuroradiology and pediatric radiology. He has won many awards in radiology and has delivered many invited lectures in national and international conferences. He has 51 peer-reviewed articles in national and international journals, and he has written 3 book chapters. Currently, he is working as assistant professor in pediatric neuroradiology and program director in pediatric radiology fellowship, UAMS Little Rock, USA. We welcome you, sir. I now request Dr. Raghu S. Ramakrishnaiah to give presentation on imaging of pituitary gland.
So, good morning, everyone. Thanks for coming. I know it's a Sunday morning. I know how precious Sunday mornings are. So, thank you all, first of all, for coming. I want to thank Dr. Sanjay for inviting me, and Dr. Bhavna and D.V. Chandrasekhar for doing such a wonderful job organizing this whole thing. And thanks to KMC for giving us the credits for CME credits. So when Sanjay asked me to give a lecture on pediatric neuroradiology, one of the things I thought about it was what are the areas I need to emphasize and where residents need to know a little bit more better, or maybe needs to get a little bit more clarity. That was my thought. And when I looked at a lot of textbooks, everything, like there's all this classic description of microadenomas, macroadenomas, but there's not much told about the subtleties of pituitary gland. So that was one of the reasons I picked up this topic. And let me move on. Oh, before that, I want to just introduce this person. He's my mentor. He's a neuroradiologist who taught me neuroradiology. He passed away last month. He went through a tough time. He went through lung malignancy and he expanded. And this talk is dedicated to him. He was such a nice person, and he, one thing I learned from him was till the last day, I think last 4 or 5 days before, or maybe a couple of weeks before, he was still in the reading room, reading stuff, even after diagnosis. And he used to be like a child in the reading room when he sees a new finding or something like that. I was amazed to see that after 40 years of neuroradiology, if he comes up with some new finding, he'll be like a child. And I just want to convey that to the residents. Keep that enthusiasm till the end of your career. So my talk, I just divided this into a few details. Like one is embryology. Anything in pediatric neuroradiology, if you don't understand the embryology part of it, it's, you're not understood the topic. The anatomy. I stress on anatomy because pediatric neuroradiology, unlike neuroradiology, the baseline is always changing. The normal is always changing. So you need to be very strong on your anatomy. And the other thing I included was developmental anomalies of the pituitary gland. And the size itself, like the pituitary gland changes its size throughout the age and also various disease processes. And tumors of the pituitary gland and infection and inflammation. That's my overview. So let's keep going. So embryology. So I think I don't want to stress too much on embryology because I'm sure none of us liked embryology during our initial days in medical school, but I still need to stress on that. So this is the embryo, and that's the neural tube. That's the very early diencephalon. So the diencephalon will sometime at around 4th week, 42 days, it forms an outpouching which drops down and comes down into the cella and forms the posterior pituitary. And this is the primitive oropharynx. And a Rathke's pouch is a pouch-like structure, which is called the Rathke's pouch, which kind of protrudes superiorly and goes and forms the anterior pituitary gland. I think that's pretty much it. I think I put it in most simplest form of embryology, but you can read about it further. Let's quickly look through anatomy of the cella and supracellular region. So the pituitary gland, this is a schematic picture. That's anterior part here, posterior here, That's the dorsum cella, just to orient you. And the pituitary gland is got a anterior pituitary and the posterior pituitary. And the posterior pituitary is part of the neurohypophysis, which comes from the hypothalamus. But it's got a central core, which is actually multiple neurons actually there. And then the anterior pituitary encases it and goes into the stalk, which forms the pars tuberalis. And that's the pituitary infundibular recess, and that's the optic chiasm, and that's the optic chiasmatic recess. Those are the two anterior recesses of the third ventricle. With this, let's go to the, this is a high-res sagittal heavily titurated sequence. And this is one thing I always tell the residents when they're sitting with me and they're scrolling through it. When they're scrolling through it, I'm okay with that. But if they don't stop in the mid-sagittal image, I always get upset. There is so much information on the mid-sagittal image that if they scroll through it, like as though you're scrolling through it, you've not spent enough time on the mid-sagittal image. So this is a mid-sagittal image. You need to stop there, let the anatomy sink in. So here, let me start with top here, corpus callosum, the fornix, and can someone tell me what this structure, this white line, the dark line is? This is the anterior wall of the third ventricle. What is it called? Sorry? I can't hear you. Yeah, lamina terminalis. Yes, that's the lamina terminalis. And what is that bead along the lamina terminalis? Anterior commissure, that's right. So when you come down, the lamina terminalis becomes the anterior wall of the chiasmatic recess. That's the optic chiasm, and that's the two optic tracts going further away, and that forms the chiasmatic recess. Then comes the pituitary stalk, and the pituitary stalk has got the infundibular recess, and that's the floor of the third ventricle hypothalamus, mammillary body. That's the pituitary stalk, anterior pituitary, and posterior pituitary. Notice how the posterior pituitary is bright on heavily titulated sequence. Unlike the regular titulated sequence, you won't see it. The classic textbook teaching is T1 brightness of posterior pituitary, but when you heavily titulate the sequence, then you will start seeing the posterior pituitary bright spot as a bright structure. Then going posteriorly, you see the mammillary body, midbrain, and the pontomesencephalic junction, pons, medulla oblongata. But I want you to notice this whole area resembles a kind of a bird, isn't it? Like it's like a hummingbird, right? The head of the bird, maybe it's trying to hold a bead or a thing, and the belly of the bird, and the tail and the wings. I just want you to think, not memorize, get a feel for that ratio of the midbrain and the pons and the medulla, and also the angle and things like that. There are two consistent arachnoid membranes in and around the cella. One is this arachnoid membrane, which attaches the optic chiasm, and it attaches to the anterior. What kind of structure is? What is this structure here? That's the cella, anterior wall of the overall cella. But what is this group? Sulcus chiasmatic is right. So the chiasmatic sulcus and this arachnoid membrane always goes to the superior margin of the chiasmatic recess. And there's another arachnoid membrane which is here. Can anyone name that? The membrane of Lilliquist. So that's a membrane of, these are two named membranes, kind of, they are consistent. They're always there when you do a high-res T2 weighted sequence. So that's about the anatomy. So there's so much of details in that area. So I want you to slow down on both on T1 and T2 sequence. You need to slow down, let the anatomy sink in, and move forward. So there's various measurement criteria given to pituitary gland. If I don't mention those numbers, it'll be incomplete. That's the reason I included these numbers here. But I want to let you know, the one thing about pituitary gland is it's in a hard shell, which is it's a cup-like structure, the cella. So the anterior-posterior dimension of the cella is almost constant unless it is a long-term pressure erosion and enlarges the cella. Otherwise, the pituitary enlarges craniocaudally, right? So if the pituitary gland is enlarged anteroposterior, that means it's a long-standing process. When the pituitary enlarges, or if it swells acutely, then it enlarges craniocaudally, right? So if you notice here, the height is what I really look for. The anteroposterior dimension, I do pay attention for that, but many times I'm paying attention to the height of the the pituitary gland, and how much of the, assume the cella is like a cup, and how much of it, of the pituitary gland fills up the cella. That's what you need to really look at. So the prepubertal kids, the average is around 6 millimeter. Puberty, 10 millimeter is the height of the pituitary gland. Males, 8 millimeter. Female, 9 millimeter. And pregnancy, 12 millimeter. If you notice, the pregnant females have the largest pituitary gland by anatomy. Let's go forward here. 10 millimeter, this is the number. As I said, a lot of times when the cell enlarges, that means it's a long-standing process. You need to pay attention to that. And I want you to, I mean, even the textbooks talk about this angle between the floor of the third ventricle and the infundibulum. It's technically not an angle. It's got a curve to it. It's a curve. So I want you to get a feel of that. What is the curve? The range is around 65 to 120 degrees. But paying attention to that, it really helps you catching some of the lesions. Like I wanted to give the examples here itself because I won't be revisiting that area here. So if you notice here, this is the patient actually, if I remember it, 8-year-old, presented with some kind of a visual disturbance. And this MR was called normal, like at least 3 or 4 times at an outside facility, and the patient was sent to our center. And when we reviewed it, if you notice here, the pituitary infundibulum does not have the normal curve to it. That's the normal curve. Here, it's as though it's moved anteriorly, and it's got a bulge to it, or a kind of a bowing deformity there. So this whole area, then when we did a high-res T2 sequence, we could see an arachnoid cyst. And can anyone name the arachnoid cyst? It's a named arachnoid cyst. So you remember I talked about this membrane of Lilliquist? So that is a cyst of Lilliquist membrane. So there's sometimes this membrane, the normal membrane should have multiple perforations in it. And the CSF should easily move across this membrane. And when the membrane is almost intact, it starts accumulating CSF and it forms a cyst. And that's actually a cyst of Lilliquist membrane. This is one of the smallest cysts of Lilliquist membrane. If you go Google image search, you'll see like massive ones, which is causing a huge preponderant cysternal enlargement. That's the infundibulum, very subtle deviation. And the importance of that is when you're suspecting a lesion in the suprasellar region, you will do a high-res area, a high-res sequence in that area. But this one, you're not suspecting anything. This was an incidental finding, right? So paying attention to the morphology of the infundibulum is very important. This is another example. This is hydrocephalus. You have a quadrigeminal plate, tectal mass, maybe a tectal dysplasia. The aqueduct is stenotic, and the third ventricle is enlarged. So you have the loss of that space between the floor of the third ventricle. The infundibulum has got a more obtuse angle. So paying attention to the morphology of the infundibulum is very important, not only to the thickness of the infundibulum. So the thickness is around 2.5 millimeter normally, but the maximum it can go up to the thickness of internal controlled basilar artery. I don't like it because the basilar artery can be really very thick sometimes, or when the infundibulum gets thicker, as thick as the basilar artery is a little bit too much thick, I feel. So here's an example where the infundibulum is very thinned out, and here is an example where the infundibulum is slightly thicker, but we'll that area later. Coming to the infundibular recess, as Bhavna was mentioning earlier, the CSF deposits go to the infundibular recess preferentially. I don't know why. Maybe it's all these nooks and corners which kind of can keep those metastatic cells better. So it's one of the areas there, and the internal acoustic meatus. That's another very sharp-edged area. That's where I see the metastasis commonly. And this is another area. So paying attention to the morphology of that infundibular recess, it should be sharp, a well-defined sharp infundibular recess. That's when you start, if you lose it, that's when you start suspecting either a dysplasia or metastasis. You know, it depends on the clinical scenario. If the patient has pituitary endocrine hormonal abnormalities, then you look for dysplasias. If a patient has got medulloblastoma, then you're looking for a metastasis, things like that. And if you notice here, it resembles a alphabet W, right? Do you see that? So alphabet W, and that infundibular recess here and the chiasmatic recess should be well defined and short. And don't try to overcall it, because if you don't do a high-res sequence, it looks blunt. So don't call it as blunted infundibular recess or chiasmatic recess on a low-resolution sequences. Always try to call that on a high-res sequence. This is a sagittal T1 weighted image. You have the posterior pituitary bright spot, the neurosecretory granules are brighter on T1, and that's the same image as the previous one. And then I want you to notice the enhancement pattern of the infundibular stalk. The anti-pituitary kind of homogeneously should enhance, and then the infundibular stalk, the infundibulum should also enhance. But if you notice here, from the previous picture here, you have the alphabet W. So this limb here, that one, and that one. The three limbs of W, the strokes of W, should not enhance. That's normal. Only this area should enhance. When you start seeing enhancement of the anterior wall of this recess here, you start questioning, is this normal or abnormal? That's the whole idea of paying attention to the enhancement pattern, right? So and also the other thing I want to draw your attention is, look at this image here. This is a coronal post-contrast T1 weighted image, and the slice is somewhere in this area, going through the anterior adenohypophysis there. So the patient was sent in for imaging for prolactinoma. Can anyone tell me what's going on? See a hypointense area here, and maybe another one here. Just feel free. I mean, there's nothing wrong commenting. Sorry? Yeah, that's exactly why I brought this slide, is because this tends to get called as microadenomas. These are normal pars lateralis of the pituitary gland. Actually, let me just explain it this schematic. This is an axial image going through the pituitary gland. That's the posterior pituitary bright spot, what you would see. And the anterior pituitary has got pars medialis, pars lateralis, and anterior lobe, like the middle portion. So let me go, okay, I've got this image here. So what you're seeing here, it enhances differentially on a dynamic sequence, and it's a transient phenomenon. It's very brief. It's brief, but so if you catch that in that time, it almost looks like microadenomas. So I don't want you to overcall it, because the moment you call it as a microadenoma, then you're subjecting the patient to a surgery, and the path report will be normal pituitary tissue, right? So always pay attention make sure that you're not overcalling the pars lateralis as a microadenoma. This is another schematic picture here. Just want to kind of briefly give you the vascular anatomy of blood supply of the pituitary gland. Supplied by inferior and superior hypophyseal artery. So that's the superior hypophyseal artery, goes here, forms the venous plexus, comes down, and then the venous drainage here. Inferior hypophyseal artery. So what's interesting is the inferior hypophyseal artery supplies the posterior pituitary, and the superior hypophyseal artery supplies the anterior pituitary. It's something to do with the embryology, because they both come from a different area. And this is the portal system. Why is it called a portal system? What is a portal system? Anyone? Yeah, you're right. I mean, you're technical. I agree with you in the sense. Basically, it does not have an arterial end to it. Every vascular bed has an arterial end and a venous end, and you have a venous plexus in between. A portal system is a system where it's got venules at both ends, like in your portal vein. So, like portal vein in the liver. So it's technically, this is a portal vein. That's the portal hypophyseal system. So that's about the vascular anatomy. And then let's move to this slide here. This is what I was trying to say. The pituitary gland changes its morphology with age, right? So this is a normal pituitary below 2 months of age. The whole anterior pituitary and the posterior pituitary is bright on T1. That's normal. and it changes to normal appearance at around 2 to 3 months of age. That's when the posterior pituitary bright spot becomes bright, and the anterior pituitary drops its signal. This is another. Let me skip this picture. Let's go here. This is what the normal pituitary we are more used to, right? So that's the anterior pituitary here, posterior pituitary bright spot, kind of fills in the cella till the brim or the top of the cup, and then you have the normal infundibulum. Whereas here, this is at puberty or pregnancy. I don't know. I mean, depending on the age and the clinical scenario, the pituitary gland is kind of bulky. Convex superior margin, but not compressing the optic chiasm or the floor of the third ventricle. This is the pituitary gland where it is kind of shrunken in size, and the suprachiasmatic, or sorry, the infrachiasmatic recess, the cisternal space there has kind of protruded into the sella turcica. So that's technically still not an empty cella, or it's working towards empty cella. But this is all normal. Everything, all individual images are normal for the given patient. If this were to be a 5-year-old, this is abnormal. If this is a 60-year-old, that becomes abnormal. So they're all normal for those particular age groups. So you need to get comfortable with calling those age groups. I'll skip on these slides because these are all, every textbook has got this picture. What are those cells which secrete different hormones? I'm going to skip on this one too. So the anti-pituitary hormones, posterior-pituitary hormones. I think you should be familiar with this by this time. With that, let's go to the anomalies of the pituitary gland. So the common anomaly of pituitary gland is an ectopic posterior pituitary, right? The posterior pituitary should be along the posterior margin of the cella. And we all pick it up. Everyone calls that. But what gets missed out is the other associated anomalies in and around the cell. We'll go to the anomalies associated with ectopic posterior pituitary bright spot in a broader spectrum, but let's focus on that area. What doesn't get called out is the anterior pituitary hyperplasia, infundibular thinning or absence infundibulum, or even kind of dysplasia of the hypothalamus. That's what gets missed. So whenever you see an ectopic posterior pituitary bright spot, you need to have two kind of a split approach to it. One, you look at the pituitary gland, assess the pituitary gland better, and then go to the other anomalies. What are the other anomalies? So septoptic dysplasia and morning glory disc anomaly, lobar holoprosencephaly, and olfactory bulb, like the olfactory bulb anomalies. They're all associated with ectopic posterior pituitary bright spot. And these are the two common ones which we see. And we see a lot of holoprosencephaly. I've not seen that close association or a strong association between the two. So let me just discuss these two entities, right? So I think I should not have put this question mark because you all see the finding. We already talked about it. Let me skip on that one. Okay, here. So this image is showing a small left optic nerve and a normal-sized right optic nerve, right? And then you have an abnormal posterior pituitary bright spot location, which is at the infundibular recess. Is there anything else going on in this patient? Septoptic dysplasia, you know that there is absence of the septum pellucidum. That's where I'm going. But can you tell that based on this image? Sorry. Can we get another mic for the Sanjay? I mean, if someone wants to, oh no, there is a mic here.
Cingulate gyrus is not very well made out.
I think it's something to do with the slide selection. You're slightly off. Cingulate gyrus was normal. Anyone else? Okay, let's, in the interest of time. Let me show you the next slide and come back to this slide, okay? So this patient has absence of the septum pellucidum. In patients with the absence of the septum pellucidum, the fornix drops down. the fornix is like, it's like a drape. It kind of holds it taut. That's the normal curvature of the fornix here when there is an intact septum pellucidum. When the septum pellucidum is missing, the fornix drops down. So even on a sagittal image, you will be able to make out an absence of the septum pellucidum, right? So absence of the septum pellucidum, ectopic posterior pituitary bright spot, that is suboptic dysplasia. So these patients, how do you know how they present? How do these patients present? Sorry. So because it's very, I mean, the reason I ask you this question is because you need to know the natural progression of all the disease processes. And when you know the natural progression, then you know where you fit in or how you can help the clinicians to make it. Yeah, otherwise, you're just giving them a diagnosis, not knowing where you fit into the whole bigger picture, right? So these are the patients who fail their vision test. These are kids. I mean, in US, all the kids go through routine vision test in the school. The nurses conduct the test, and here it most probably is the ophthalmologist. So, kids can't see it and they go to the ophthalmologist, they fail the vision test, the kids. And the ophthalmologists send them for either MR or endocrine workup. Because the reason is when they fail the vision test, when they look through their fundoscope, they see optic nerve hypoplasia. And these patients should get growth hormone supplementation. Otherwise, they will fail their growth. They don't achieve their target height. So they need to get a complete endocrine workup, and they will get their growth hormone supplementation. So here's the same. I'll go to the next slide here. The reason is, this is one, actually it's still the largest paper in the literature. We published this in 2011. There is two different schools of thought, in US or throughout the world, where ophthalmologists see an optic nerve hypoplasia, and then you can either go through radiology, get an MR imaging to look for pituitary anomalies, or just go blanket search for all the hormonal abnormalities. So what we did was we studied a large population of optic nerve hypoplasia patients. We realized MR is very sensitive and specific if you do a good protocol and if you know what you're looking for. But the other school of thought is like MR is too expensive, let's get all the endocrine workup. So different ways of approach to the same problem. But we do this. If the patient has hypoplasia, we get an MR, and then based on the MR findings, then you look for the endocrine abnormalities. Quickly going to morning glory disc anomaly. This is a anomaly of the optic disc itself. And on the first look, it looks like a coloboma. It's like a pit at the optic disc, but it's actually not a coloboma. It's an anomaly by itself. It's a kind of a dysplastic insertion of the optic nerve into the globe here. And it's got if you notice, this is on the left side, which is normal. The CSF should extend all the way to the choroid. The optic nerve, you're not seeing it here because it's in a different slice. But otherwise, the CSF should touch the posterior margin of the choroid. Whereas here, there's a dysplastic tissue which kind of doesn't go all the way to the optic globe. That's the morning glory disc anomaly. The reason it's been called morning glory disc anomaly is because ophthalmologists see it like a flower, morning glory. These patients will invariably have abnormalities of the optic chiasm, and the pituitary bright spot will be dysplastic or kind of in an ectopic location. The pituitary abnormalities I see it in around 50% of the patients, but the chiasmatic abnormality is almost always there. So take-home message is when you see an ectopic posterior pituitary bright spot, one, look for minor anomalies in and around the pituitary, which is hypoplastic pituitary gland, antipituitary hypothalamus, infundibulum. Also look for optic nerves, for septoptic dysplasia, and also other anomalies. Let's quickly go to persistent craniopharyngeal canal. We talked about the anatomy. This is a schematic picture where the pituitary gland, when it formed, there was a craniopharyngeal canal where the Radke's pouch kind of migrated superiorly. Sometimes the canal doesn't get obliterated completely. It could be just fat-filled or fibrous tissue-filled canal. Sometimes there can be cell rests from the pituitary gland left behind in the canal, and also in the nasopharyngeal submucosa, like submucosal rests in the area. Why is it important to recognize this? The reason is, you need to differentiate this from other destructive processes of the bone. Like here is an axial image through the sphenoid bone, and that's a well-corticated tubular defect in the sphenoid bone running craniocaudally. And when you see on an MR, you see that canal here. The pituitary gland is still very much at the floor of the cella. And if you really carefully look at it, it does not have any enhancement. It's a fibrous tissue. It's a persistent craniopharyngeal. You cannot do nothing with it. But you need to differentiate that with a, let me go back to the other slide later, but let me finish up this cephalocele. You need to differentiate that with a cephalocele where you have herniating meninges. It goes into through the sphenoid bone into the nasopharyngeal submucosa here. This is a treatable or to be treated lesion, whereas a persistent craniopharyngeal canal, most often it's an incidental finding. This image here, actually it was an interesting case. I had to put it here because it just fits in right here. We saw this lesion in the sphenoid sinus. Initially we thought, okay, maybe it is aggressive sinus disease eroding the bone. But later the patient came back, it was slowly progressing. And then if you notice, there is a pattern to it. It's got a kind of an oblong look to it. And the sinus is very clean. If this were to be sinus disease, elsewhere there should have been some mucosal thickening. Whereas this one is kind of oblong in that area. We called it as an aggressive lesion. We don't know what it is, but it came out. And then the path was actually a pituitary adenoma. This is a pituitary adenoma coming from the cell res, which did not migrate through the pharyngeal canal. So I want you to keep that in mind when you see a lesion in the right location, it could be pituitary adenoma. So we talked about this slide, cephalocele. So these patients present with spontaneous rhinorrhea, CSF rhinorrhea, or infection, things like that. And so basically, when you see a cephalocele, there are a few things which you want to comment on. One, where is the optic chiasm? Where is the posterior pituitary, and where is the anterior pituitary? Those are the three things which you definitely need to comment, because if you don't mention those things, one, for the surgeon, when they go in to close it, they need to know where it is. And second is, the pituitary gland abnormalities are better. The endocrine abnormalities should be predicted by MR. Let me put it that way. So here's side-by-side example. Here, that's a persistent craniopharyngeal canal. The optic chiasm is kind of sagging, but it's still in the right location. And this is an intact floor with the pituitary gland here, whereas this one is a cephalocele. Rathke cleft remnant. This is one of the areas where radiologists overcall. Like, so you all know what is a Rathke cleft remnant or a Rathke cleft cyst, which is actually from our embryology. You have this Rathke pouch, and this central portion should obliterate completely. But sometimes it just stays behind and forms a cleft-like structure, which is like a hypointense area there. This tends to get called as Rathke cleft cyst. And the moment you call it as a Rathke cleft cyst, then parents will get worked up and they, oh yeah, my kid has got a cyst in the brain. You don't want to say that. You want to call it as a Rathke cleft remnant, which is almost like it's a cleft, right? So Rathke cleft remnant without any mass effect. There is no mass effect on the antipituitary. There is no mass effect on the posterior pituitary. And there's just a plate-like, a linear structure, which is a plate-like in the pars intermedia of the pituitary gland. In contrast to Rathke cleft cyst, which is usually cyst-like, right, here. And that's a sagittal T2, which is hypointense. It could be hyperintense or hypointense. In this patient, it is hypointense. And on T1, it could be bright, depending on the protein content, or it could be isointense or hypointense, again, based on the protein content of blood products, the contents of the cyst. On post-contrast, the anterior pituitary enhances, so there is a relative hypointensity of the Rathke cleft cyst. So this is what I call it as Rathke cleft cyst, where there is a real cyst with some degree of mass effect on the anterior pituitary. Don't overcall Rathke cleft remnant, which is this one. Okay, let's go to this one. This This is a very rare dysplasia. I think in the last 11 years of doing only dedicated peds neuro, I've seen only 4 cases. So that gives you an idea how rare it is. But the reason I wanted to add this is it's a very typical findings, and it can be mistaken for different other various abnormalities. So when you see it, you want to pick it up, because you may not see it, or you might see it, but still, it's very important to pick up this lesion, frontonasal dysplasia, or median cleft lip syndrome. Let me skip this slide here. Okay, so the pituitary abnormality in this syndrome is basically a duplication of the infundibulum. The pituitary infundibulum has got duplicated, and the sella turcica is widened in the lateral. Transverse dimension of the sella turcica is wider. These patients will have very classic anomalies in the midline, which goes in this axis, like here. Like if you notice here, there is some kind of a mass-like structure in the nasal cavity or oral cavity. Then when you go more posteriorly, you already talked about the pituitary, which is duplicated pituitary. Then you see a mass-like lesion here, right? Which is along the floor of the third ventricle. Then you go more posteriorly, the tectum looks dysplastic, aqueduct is very wide open, and there is agenesis of the corpus callosum. And also, in between, you have the basilar artery. Let me just show you, that's a basilar artery. The basilar artery is duplicated. Here's the thing. If for an untrained eye, if you really don't pay attention to this area, it almost looks like a mass of the opticochiasmatic area. And this patient was called as hypothalamic glioma or opticochiasmatic glioma, and with other anomalies. That it was colored that way. So I want you to notice this is just a fusion mass. It's a dysplastic mammillary body and tuber cinereum as a single midline mass. So I don't want you to overcall this, but I want you to recognize all these abnormalities which occur in that axis there. This is a very interesting picture. Same patient, the mass in the midline nasopharynx was a dermoid, and there was multiple teeth in the dermoid, and that's the native teeth here. And that's the teeth within the dermoid cyst. There's a 3D reconstruction of the skull. That's a dermoid cyst. Notice the hypertelorism, widened intraocular distance. Right? So, pituitary, I mean, we are switching gears now. A lot of people can see different things there, but size of the pituitary gland matters, right? So the empty sella syndrome is what we commonly see, we routinely see. And sometimes people kind of overcall it or undercall it, or just say, oh, empty sella seen, and move on. But I want you to really value that word, okay? So a couple of things about empty sella. Empty sella, you need to really look at the morphology. The infundibulum just goes to the very edge of the tuber dorsum cella and just dips in, just right at the margin. That's normal or the usual appearance of an empty sella. Why does it happen like that? Any idea? Sorry? Sorry? Yes, you're right. The diaphragm cell is wider, but the reason, I mean, it could have, the CSF could have herniated posterior to the infundibulum. That's my question. So the infundibulum, there is a supradiaphragmatic cistern, which is a CSF space, and there is a reflection of the arachnoid membrane which drapes along the infundibulum and goes to the Lilliquist membrane, which we talked about. So most of these cisternal spaces are anterior to the infundibulum, and that herniates into the sella. So that is a classic empty sella syndrome. Sometimes the sella also slightly enlarged, and the pituitary gland is thinned out along the floor of the sella turcica. That's the empty sella. And if you go to the literature, there's always idiopathic empty sella and then secondary empty sella. I somehow don't like the word secondary empty sella because there's a diagnosis to it, right? So I usually call it an empty sella if it is idiopathic. If you don't have a reason for it, I call it so basically I'm trying to tell the clinician, don't worry about it, move on. Whereas if it is a secondary thing, you need to really draw their attention to the actual cause of the empty sella rather than calling it as an empty sella, right? In pediatric age group, this is another example where the pituitary looks smaller. So we have got a theme here. small-sized pituitary gland. So we finish the empty cella. This is hypoplasia of the pituitary. Notice how the infundibulum goes to the mid portion of the cella. This is a normal the appearance of the infundibulum when it dips into the cella when there is hypoplastic pituitary. The cisternal spaces are equal on both the ends there. The hypoplasia can be only of the pituitary, or it could be hypoplasia of the hypothalamic pathway, hypothalamic hypophyseal pathway. The whole area could be hypoplastic. So when you call it as hypoplasia of the pituitary gland, you need to say it's isolated pituitary gland hypoplasia versus hypoplasia of the floor of the third ventricle and the pituitary gland. So another example here, the small-sized pituitary. The pituitary gland is very small and increased CSF space, and this gets called as empty cella, right? So my suggestion to you is whenever you see this, you always go to your coronal T2 or an axial T2 image to look for the papilledema, signs of papilledema. You don't call this as empty cella without looking at this image. You almost automatically, just like you go to the T2 image and then come back to the thing and then call it. Because I've seen this residents kind of preliminate it as empty cell and see and move on. But in fact, it was pseudotumor cerebri. And I don't want to elaborate on the pseudotumor cerebri. I'm sure you're all familiar with it. So side-by-side comparison, hypoplasia of the pituitary, almost small-sized pituitary, same, the infundibulum goes to the center. Pseudotumor cerebri, look for signs of raised ICP on the orbits. That's a classic empty cella. So the classic empty cella is when I use the term empty cella syndrome. Otherwise, rest everything, I give the diagnosis why there is an increased CSF space. So we are switching gears. So hypoplasia of the pituitary gland. And again, it depends on the clinical scenario. If the patient is at puberty, that's normal, again, pregnancy. The other two things which we routinely see as hypoplasia is, like if the patient is not at the right age for puberty or pregnant, then I open up the chart and look for end organ resistance, like something like hypothyroidism. Patients with hypothyroidism can have a swollen pituitary gland because the end organ is resistant, the pituitary gland is trying to overfunction, and it swells up. Does anyone know what is Nelson syndrome? Sorry? Correct. So did you say adrenalectomy? Yeah. So post-adrenalectomy, hyperstimulation of the pituitary gland is Nelson syndrome. So this picture would fit into any of these diagnoses. So you need to really correlate clinically and put the right diagnosis to this patient actually was a pubertal patient, but I just used the same image, and the clinical scenarios can be different, right? Again, the theme is swollen pituitary gland. Like, this is a companion case for pseudotumor cerebri. This is what we are very familiar. The residents always pick up this finding, which is the diagnosis is intracranial hypotension. Could be due to a CSF leak somewhere else in the spinal column or in nerve avulsion or some kind of a CSF leak somewhere. The pachymeninges really enhanced diffusely. It's a smooth, diffuse pachymeningeal enhancement. Everyone picks it up. Sometimes it could be very subtle, but other findings you need to be familiar with are the complete collapsing of the optic nerve sheaths around the optic nerve. Like the CSF is completely missing in the optic nerve sheaths. And then swelling of the pituitary gland. Swelling of the pituitary gland is a very nice finding. It's been very useful for me. I always pick up this finding and then pay attention, because this is what you see in the pre-contrast. You'll see the swollen pituitary gland, not normal for age. Why is this pituitary gland swollen? Then on the post-contrast, you see the pachymeningeal enhancement. So you've already made the diagnosis of hypotension even before you're seeing diffuse pachymeningeal enhancement, right? So, and what else is shown in this picture? Sorry? Yes, drooping of the splenium, correct. And what else? One other thing. Sorry? Correct. That's the other one. So there's engorgement of the sinus, like inferior sagittal sinus is a little bit too swollen. I mean, and so it's not only the engorgement of the sinuses, it's actually diffuse enhancement of the falx cerebri also, part of the pachymeningeal enhancement and the engorged sinuses, right? So all features of intracranial hypotension don't be fixated on only this imaging finding where there is diffuse pachymeningeal enhancement. Okay, so again, we are still on the same theme, the size of the pituitary gland. This has happened just 2 weeks back when I was preparing this talk. So this was sent as, this patient went to an outside diagnostic center where for trivial trauma, and the radio, I think it was a radiologist, teleradiologist who read it as an enhancing mass in the suprasellar region here. So what do you think it is? What could it be? I mean, this is the classic resident teaching, right? So enhancing suprasellar mass, well-defined, would be, what are the things you need to? It could be aneurysm, right? It could be an aneurysm, or it could be a suprasellar mass, or whatever. So he called it as possibly a suprasellar aneurysm or a meningioma. That's a classic textbook differential, but it does not really fit into that. So this patient, we did not rescan this patient. The neurosurgeons called me in the night, and they wanted an emergent, because it's technically, if it is an aneurysm, it's a large aneurysm. They wanted to get a complete workup middle of the night. So this is a scout picture. It's not a radiograph. It's a scout picture of the same CT. Can anyone comment on the scout? Cella is correct. That's a wonderful. That's a very nice pickup, actually. So the cella is very shallow. When you see the cella shallow, you need to make two judgments. One is the shallow cella. The cella is very shallow because the cella is eroded, or did it not form well? That's the question. So what you do is you look at the planum sphenoidal. The planum sphenoidal almost continues like a flat line almost. There is really no cella which developed. What else is going on in that radiograph? Anything else? I see what you're saying, but I'll give it, maybe most probably, there is some cervical spinal anomaly. I don't know. I haven't looked at, because we didn't scan that patient, that area. Sorry? Correct. No, you got the finding correct, but it is not pycnotic osteosis. It's a antagonial notch, what you're talking about. So that's the reverse curve of the mandible. This is classic Treacher-Collin syndrome, right? So the Treacher-Collin syndrome, Pereira-Robin syndrome, all those syndromic patients have a midfacial hypoplasia. Basically, the skull base and the mandible did not form well. So this was just a skull base. Let me put it as a broad spectrum, skull-based dysplasias. So skull-based dysplasias will have a shallow cella turcica, and the pituitary gland will stand out of the flat cella turcica. It almost mimics like an aneurysm or a mass lesion in the suprasellar region. When I told this to the neurosurgeon, well, it's normal, don't worry about it. They're like, you're missing an aneurysm. It was called as a 10 millimeter aneurysm, and you're not even seeing it. I said, don't worry about it. And then we reconstructed these images. But still, they got the MR angiogram of the same patient just to be 100% sure, and there was no aneurysm. So it's almost like an apple on the table. It's like standing out, and the pituitary gland can look hypertrophic. What's going on in this patient? Again, the pituitary gland is kind of plumpy, bulky. Anyone? It's the same theme. There's a theme going on, right? But why do you think the theme is the same. The pituitary gland is large for the cella. The cella is shallow. But why do you think this patient has a shallow cella? Right. What is it? So, can you be louder? Actually, a good thought. I mean, I never thought about it, but it could be an overshunting, but it did not have features of overshunting, like our hypotension, right? So yeah, that's a good thought. Definitely, that's in the differential. But basically, all patients this is most probably a patient with complicated hydrocephalus. Before putting the shunt, there was a massive hydrocephalus, and it erodes the cella. It kind of remodels the dorsum cella, erodes the cella, and the pituitary gland is squeezed and flattened out. Then when you shunt the patient, the ventricles drops to normal, but the bone doesn't develop back to normal. So the cella is still shallow. And the normal pituitary is large for the deformed or a shallow cella which was eroded by the hydrocephalus. This is what we see routinely because we have all these patients who have got massive hydrocephalus, we were shunted, treated, and then we see this enlarged pituitary gland, or as though it is enlarged, it's a normal pituitary gland, treated hydrocephalus. I couldn't stop adding this picture here because we were talking about the shapes of the cella, a J-shaped cella turcica in a patient with mucopolysaccharidosis. That's the enlarged perivascular spaces of the patient with MPS. Tumors. I think most of the textbooks really, when they talk about pituitary gland, they focus so much on the tumors, they really leave behind all the subtle findings of pituitary gland. Let's go to tumors. We all know this. This is so basic. I don't want to spend too much time on this. Less than 10 millimeter microadenoma, more than 10 millimeter macroadenoma. 24% of them are non-functioning. Majority of them can be functioning, microadenomas. And most of the microadenomas, functioning microadenomas, are prolactin-secreting tumors. And they present with amenorrhea, galactorrhea, growth hormone, acromegaly. It's very rare to see acromegaly these days. Cushing's disease, ACTH-secreting microadenomas. Sometimes even absent pituitary infundibulum can mimic a microadenoma by endocrine workup. That's because of the negative control from the hypothalamus is disrupted by the interruption of the infundibulum. It mimics by endocrine workup as microadenomas. Pay attention to that. I never call confidently presence or absence of microadenoma without a dynamic sequence. Sometimes we may not get a dynamic sequence, but I say, okay, I don't see a microadenoma on this MR of the brain without dynamic sequence. That's my report. Because you're sending this patient to surgery or you're taking the patient away from treatment based on a like an MR without dynamic sequence. That's not right. Always get your dynamic sequence, set your protocols right. There are various other subtle findings, infundibular deviation, double flooring of the cella turcica, all massive push, pull, all those things. Just a few important findings. ACTH-secreting microadenomas are usually the smallest ones. Prolactin-secreting tumors are lateral in position. ACTH, TSH, FSH, all these secreting tumors are central in position. How do I use this information? Just because it's small, I don't call it as ACTH secreting tumor. Or just because it's on the lateral aspect of the gland, I don't call it as, oh yeah, this is in the lateral aspect of the gland, it's prolactin secreting microadenoma. I don't make those diagnoses. I use it in this information in a reverse way. So I already know what hormone it is secreting. So I know where to focus my attention. It's like if it is prolactin, you'll have to look at the whole pituitary gland, but you're still paying attention to the lateral. So you use this information in a reverse way to reverse engineer where to look for, things like that. But otherwise, I never make the diagnosis as, okay, this is the microadenoma, or presence or absence. That's all it is. This is a good example of microadenoma. It's on the left side of the gland there. Macroadenoma, more than 10 millimeter. It enlarges the cella turcica. It's got a very classic appearance to it. It's got a snowman appearance, the kind of a waist. That's the diaphragma cella constricting the tumor and it's going out of the cella turcica. There are a few things which the surgeons want to know before taking this patient for surgery. I'm sure you're all familiar with this classification here, or the grading thing. That's just to orient for the first year or second year residents. This is the pituitary gland. It's a coronal picture. That's a cavernous sinus. These are the cranial nerves along the lateral walls of the cavernous sinus. That's the internal carotid artery, right? So the pituitary adenomas, if they are medial to this medial line, is grade 0. And this is about the the grading is for the invasion of the sinus itself. It's not about the grading of the tumor. Don't mistake it for that one. So, and you see the numbers, it indicates wherever the tumor goes, that's the grading. Here's a good example of grade 4 invasion on the right side. It's going under the ICA, going all the way. The cavernous sinus wall is kind of bulging outwards, things like that. Same patient on the left side, it's almost 0 here. It's just the medial to the medial line there, right? You need to give those information to the surgeons. Where's the tumor? What is it invading? How is it increasing the ICA? There are other few things which you want to comment. The surgeons, they assess the scan themselves, respect their views, but that doesn't let you away from your responsibilities of not calling those findings, right? Because when the surgeons go in, they need to look at, they know how to read their scan to some extent. But you need to, you still need to pay attention to those things. So different things that you want to talk about would be pneumatization level of the sphenoid bone, various degrees of pneumatization. There's grading level. I really don't grade it, but I just pay attention to that. And I mention, is it well pneumatized, not pneumatized? That's where I leave there. And if there's fulminant sinus disease, acute sinus disease, you don't want the surgeons to go in through an infected sinus, right? And you look for vascular structures which protrude into the sinus or on the path to the cellum. Right here, there is an example of the carotid artery, descent carotid artery, which is kind of protruding into the sphenoid sinus, or medialized ICS, very narrow ICS coming into the sella turcica. So you want to comment on those things. Could be septations here. That's a midline septation. Because sometimes it could be deviated. When the neurosurgeons, when they go through the scope, through the transsphenoidal approach, they look at the septum and they think that is the midline. If the septum itself is paramidline or to one side of the thing, they think that is the midline and they go straight into that thing. They may enter the cavernous sinus or injure the ICA. So I always comment on this part though. If there is a severe deformity or asymmetry of the sphenoid sinus, I mentioned that in this patient and on many times if I have to draw their attention, I put it in a single sentence. Patient with macroadenoma of the thing, the sphenoid is well pneumatized, but the septum is asymmetric, or the sphenoid sinus is asymmetric. You draw their attention. That's about the microadenomas. I really didn't want to take too much time on that macroadenomas because I'm pretty sure everyone is familiar with those things. Switching gears, this is a different patient. What are you seeing? Let's comment on the first image. This is the sagittal fat side T1, non-contrast. Sorry? Pituitary infundibulum is thickened. That's right. 1 point. What else? The absence of the posterior pituitary bright spot, right? So thick infundibulum, absent posterior pituitary bright spot. What are we seeing on this radiograph? This is a frontal radiograph of the skull. Correct. So this is for the other audience, there is a lytic lesion here, which is destroying or eroding or lytic lesion of the skull in the mastoid region, temporal bone region. You can actually see the external ear is kind of drooping. It's a mass lesion there. So classic histiocytosis. This patient actually presented with polydipsia to the ED. Unfortunately, this lesion was missed on the initial scan. That was an unfortunate thing. And later, this was picked up at a later scan, but initial scan it was missed. But anyway, so the CT of the temporal bone showed this large lytic lesion here. Classic histiocytosis location. Infundibulum is thick, as I mentioned, and it enhances intensely. This is classic histiocytosis presentation. If you're practicing dedicated pediatric radiology, you'll see a lot of these patients. A lot in the sense like maybe 4 or 5 cases in a year. That itself is a large number, presenting as polydipsia, diabetes insipidus. Craniopharyngiomas, because I think during our residence we all read about craniopharyngioma, cystic appearing, peripheral calcified mass in a pediatric age group, the craniopharyngioma. The differential is it could be a peripherally calcified aneurysm wall. That's what we talk about. So craniopharyngiomas, so we're all again familiar with this one. I just want to touch on a few things. There's bimodal age distribution. Don't ignore craniopharyngioma as a differential in an adult patient in a classic location, right? Calcifications is the other important thing. And the tumors enlarge the cell, extend superiorly. Unlike macroadenoma, they don't usually have a notch. That indicates the tumor might have come somewhere in between, like somewhere in that axis. Sometimes I've seen that notch also, but not always. Right, so it's these patients present with localized pressure effect on the optic chiasm and visual disturbance. And management, that's where I want to draw your attention on. I think I'm reasonably confident that you're all familiar with the craniopharyngioma. Again, you talk about cavernous sinus involvement and ICA encasement, what it is doing to the optic chiasm, things like that. What's the management, current management? Did I hear research? Anyone? What are the, so that's the reason I always mention, always know your patient's natural progression. What happened to the patient after you've made the diagnosis? What happens to your patients with craniopharyngiomas? Surgery? That's an old, I'm not trying to say that's, but it's obsolete. Now, no one resects, or you should not resect the craniopharyngiomas because these patients becomes completely hypopit and they will be on hormonal replacement for the rest of their life. The current standard is usually to put a Ommaya reservoir. You put an Ommaya reservoir, inject the chemotherapy straight into the cyst, decompress the cyst. And I've seen neurosurgeons decompressing the cyst like 3 or 4 times in a span of 4 or 5 years. When it enlarges, they evacuate it and then put a chemotherapeutic agent and follow up. That way, you don't have to replace the pituitary hormones to these patients. So, Ommaya reservoir. This is the Ommaya reservoir. Here, that's the reservoir. That's a tube running into the craniopharyngioma, which is kind of decompressed. So, and also the surgery can be very messy because the content of the cyst content is very sticky. It's called, it's kind of, they compare it to the crank oil. They're very sticky substance, and when they try to take it out, when they try to peel it from the adjacent structures, the adventitia of the vessels can get injured and they form pseudoaneurysms. So it's easier to treat it with Ommaya shunt. The patients really do well with Ommaya reservoir. So as Dr. Balmer talked about, so pituitary infundibular rhesus metastasis, look for those lesions. I think she's really elaborated on that, so I'll skip this slide. This is a lesion, very similar looking lesion, but pre-contrast, iso-intense, post-contrast, iso-intense. It's a hamartoma. And these patients, you're right on the thing, and they present with typical gelastic seizures, which are kind of it is compared to smile, kind of a smiling, but it's actually not, they're not trying to smile, they're just twitches of the facial muscle. And they present with precocious puberty, right? They have various associations. Let's skip on that. We'll go to the infection inflammation. Actually, this is a very nice, this is not a pediatric patient, but I wanted to include this. So this was a second scan. This patient presented with headaches, that's it. That was the history. I want to hide the rest of the history. That was the chief complaint at the time of the scan. And the reading radiologist noticed this pituitary gland was enlarged, maybe he measured it. But what was interesting was there was a C-spine of the CT of the cervical spine, which was done for a totally unrelated issue like trauma. And the pituitary gland was like this, small. And this was I think this was a 35 or 40-year-old patient. So this is unusual for a 40-year-old to swell up the pituitary gland. And this patient had history of myeloma. What do you think the diagnosis is? Patient had history of myeloma. It's a treatment-induced hypophysitis. Where I work, it's one of the largest centers for, it used to be at least, one of the largest centers for myeloma, and we used to see a lot of complications of myeloma. But anyway, so you want to keep that in mind. The common one would be lymphocytic hypophysitis or pregnancy-induced. or patients with pregnancy. The same lines, I just want to touch base on neurosarcoid, patient with bilateral enlarged hilar adenopathy and diffuse leptomeningeal enhancement on a cellular supracellular mass, classic neurosarcoid appearance. Pituitary apoplexy, so which is actually hemorrhage into the pituitary gland. It could be normal or an abnormal pituitary gland with a mass. These patients present with classic headache, visual defects because rapid enlargement of the pituitary gland compressing the optichiasm and alter sensorium. Here's a good example there. That's a pituitary gland. The hypointense area is the hemorrhage within the pituitary gland. On pre-contrast, kind of is bright and merging with the rest of the pituitary. On post-contrast, actually the rest of the gland enhances, and that's pituitary apoplexy. It's not a good example. This is what I had. Some of those apoplexies can be really massive enlargement. I don't think this is a good example, but this is actually from a journal, Sheehan syndrome, where the patient post-portal hypotension-induced infarction of the pituitary gland. That's a non-enhancing, very irregular looking pituitary gland. So that's Sheehan syndrome. So I covered all those things. If you have any questions, we can always discuss. Thank you. That's my son, Adi. I want to thank him because when I prepare all these talks, I spend a lot of time on this. It's actually his time away from me. So I want to thank him for letting me do this. So thank you.
Thank you, sir. That was a very interesting session. Any questions?
So they sent for some other investigation. So almost 1 or 2 patients in around 30-40 patients we see this. Should we make a note for all the patients or should we not?
So that's exactly what my message was. When you see an empty cellar, before calling it an empty cellar, rule out other things like signs of raised ICP or papilledema. Look for all the clues, and if it is the right age group, like if the patient has a 3-year-old, most probably it's a hypoplasia. So look for signs of hypoplasia or raised ICP things, and then if there's nothing else, you call it as empty cellar syndrome. Yeah. And most probably it is an incidental. Most commonly it's an incidental thing.
Sir, how confidently can we differentiate microadenoma from the normal non-enhancing sparse lateralis? One thing is, you said there is deviation of the stalk that we can consider.
How confident? It depends. It depends from patient to patient. One. So if there is a definite abnormal endocrine workup, then you're looking for it, and if you see a lesion, it's most probably microadenoma. Then, if it is a non-function, that's when you're in trouble, like you're in a dilemma whether to call it or not. But either way, they don't go in for surgery. So I try to err on the side of calling it as positive because it's a non-functioning microadenoma. Then you're not causing any harm by calling it as thing. So I have more confidence. It's more of a feel to it.
You mentioned about this highly T2 weighted imaging, sir. Now, we have is a 3 Tesla Phillips achiever, of which do you think that we could achieve it?
Did you say 3 Tesla Siemens?
Phillips achiever.
Phillips achiever. Yeah. I mean, it's called balanced fast field echo
Do
sequence.
you have to get the software separately?
No, it's one of the basic sequences. It's always available.
It's not the normal T2,
Yeah, because
but it's a highly T2.
that image which you saw is a 20-year-old scanner, 1.5 Tesla Phillips. So the sequence was not there 20 years back, but it was loaded onto the system, and the newer scanners always get those.
Thank you.
Sequences.
Sir, in an asymptomatic patient on a lateral skull radiograph, if we see a widened cella and the patient has not come for that, then should we advise further workup for this patient to look for some pituitary mass or something?
So let me understand your question. So you see an enlarged cella on a radiograph.
Yeah.
So do you recommend for a further
Yeah,
investigation?
and the patient has not come for that. He has done the radiograph for some other cause, and we find a large widened cella.
Right.
So,
So
should
even
we
on-
advise that further investigations?
Sure. So again, as I said, always tell the residents, try to spend some time on all tricky cases. Try to get as much information about the scan, right? So when I see that, I always look for any signs of raised ICP. Is there any increased convolutional marking? Is the enlarged cellar due to remodeling? Is the cellar margins clean? Or is it thinned out? The floor is it thinned out? When you see an enlarged cellar, you look for, is the walls of the cellar thinned out or eroded, destroyed? Increased in, convolution markings. When you see all those things, and if there's any one of those things, you ask for workup. If it is a totally asymptomatic patient, most probably not, unless it is a huge, like 13, 14 millimeter cellar, then I won't.
Sir, how will we distinguish Rathke's club cyst and small intra-pituitary hemorrhage if both are T1
Sorry,
hyperintense?
I didn't get your question.
If both are T1 hyperintense, how can we distinguish Rathke's
Both
cyst?
are T1 hyper. Sorry.
Rathke's and pituitary hemorrhage.
From hemorrhage? You don't have to. I mean, that's the thing. I mean, many a times when I see a Rathke cyst which is bright, I say the brightness is due to the content of the cyst. It could be high proteinaceous content or blood product. That's how I would word it. Unless there's a rapid change in size, that's when it is hemorrhage, when you call it as a hemorrhagic cyst. If there is no rapid change in size, I wouldn't call that as a hemorrhage. It is most probably either old blood products or just a mucus content or like a high proteinaceous content.
So I guess if you had just one exam and you just happened to see it as bright, then would you include hemorrhage in your differential at all?
No, as I said, I don't call it as hemorrhage. I call it as old blood products, because that could be just leaking blood, like blood leaching through the, like just seeping into the cyst. So when you call it as hemorrhage, it's a hematoma, which is causing mass effect, swelling of the gland, compression of the optic chiasm. If I don't see any of those findings, I don't call it as hemorrhage. I call it as old blood products in the cyst. Did I answer your question? Thank you.
Thank you, sir.